Again, we are recording this webinar. So welcome. We have had excellent response to Dr. Easterbrook come in here today. Obviously, this is a subject that our members is greatly interested in. And Dr. Easterbrook, welcome. So a little bit about Dr. Easterbrook. Dr. Easterbrook is a professor of ophthalmology at the University of Toronto. He's also on staff at at St. Michael's Hospital, Toronto Western Hospital, and he has an office at Bay Street and College. Over many years, he's had the opportunity to see many patients on Plaquenil referred by rheumatologists and dermatologists. With improved testing methods, Dr. Easterbrook and team are able to pick up early the very rare situations where the drug may affect the eyes. Today, this short talk today will illustrate these tests that Dr. Easterbrook is using in his deal and treating his lupus patients. Welcome, Dr. Easterbrook. We're very happy to have you here, and we look forward to your presentation.
Thank you very much. I'm just going to, let's see, can I shut that down? Okay, now if I, now just a second, okay. I'd like this to be informal. If you have any questions as we go along, is that appropriate to interrupt?
Well, it's up to you, Dr. Easterbrook. What we normally do is we will let you do your presentation. We did put out a request for members to forward in their questions ahead of time. So I do have a number of questions that was forwarded. So we'll deal with those at first.
Okay.
And then afterwards, if we do have time, because we have such a large group, I ask that you do not post your questions in the chat, but put your name down and we will make a note of your name. And if we do have the time after those questions have been answered, then I will call that name and then we will be able to have you ask Dr. Easterbrook during that question during question period. Okay, so what we will do is we will mute everyone during the presentation. And then after the presentation, I will present those questions to Dr. Easterbrook, and then we will open it up for additional questions if we have time, okay?
Okay, well, thank you. I'm happy to, by email, answer questions as well.
Okay.
What I'd like to do is go through what we've learned. I've been blessed, really, to see so many patients over so many years from the rheumatologists all around Ontario. And things have certainly changed, and we'll talk about that in a second. I want to—
Sorry, Dr. Easterbrook, sorry to interrupt.
Yep.
If you could just click on play from start so that you can show the presentation.
Okay.
Thank you, and then just navigate throughout. Thank you.
Thank you. So I want to review some of the tests and suggest the guidelines because we're over-testing our patients. And the real question, is it safe? And I reviewed in 6 months last year, every patient had been on the drug 20 years I looked at, and only one had met retinopathy, which was mild. So the incidence is very, very small. The risks are very small. We can pick up any retinopathy simply and early. Taking pictures of the eye, for instance, are useless because that only occurs when there's late signs of retinopathy, but we'll talk about that. You remember there are two drugs, the chloroquine, which some of you may still be on. It's considered more toxic than hydroxychloroquine, and that's why most of us are seeing patients. Now, what tests are presently being done? Visual acuity is obviously important. Color vision is not, it's a useful test if you have moderate changes, because when you do color vision, everybody should do it as fast as the doctor does. Slit lamp examination is important. We're going to talk about visual fields. Fundus examination, looking at the macula, is not that important, or taking pictures of it is not that important because those changes are late. We want to pick up changes early, because if you have early changes from Plaquenil and you stop the drug or cut the drug in half, these patients remain with normal vision. So we'll talk about that in a minute. Visual fields we're going to discuss shortly. I'll skip this for a second. Some of you may have been given the AMSR years ago, and it was a very useful test because our patients are young, they're bright, they pick up these changes, and these are called scotomas, and a patient will, if they have early retinopathy, will look at the black spot and say those squares are faded. And then if it gets worse, it forms a circle. And these changes are all within, these are degrees, they're all within 2 to 10 degrees. And that is the same field that we use when you put your chin in that white bowl and have a Humphrey visual field test. We're checking the central 10 degrees of vision. So the gold standard still is visual field changes. However, we want objective changes. The visual fields are subjective, but our patients are generally young, they're quick, they're sharp, and any changes are reproducible. However, they're not objective. So we're looking for other tests. I'm just going to go over these briefly. The multifocal is the new test that's only available in London and Toronto. It's very sensitive, but it may be too sensitive. And basically the patient sits in front of a flashing screen, and I'm sure some of you had this. Little fibers are placed across the inferior lid margin. And this is what the normal pattern is. And you get depression. You can see depression around that spike in patients who have very early retinopathy. And this is an example, again, normal, and these blue areas are showing depression in that 2 to 8 degree area. So it's a very sensitive test, but we don't know if it's too sensitive. We may be picking up patients that have lupus and are not on the drug. So we have done a study and are doing a study where we're trying to get this test done before you go on Plaquenil. OCT is readily available, and I'm sure you've all had it or many have had it. And I'll show you some examples. These are advanced cases, and I don't know if you can see, I don't have a pointer, do I? Okay. There's a junction, it says junction of inner, where the photoreceptors are, over on one side or the other, there'll be a gap. And I'll show you another one. For instance, this is the visual field, and what happens is, as you know, you sit in front of the screen, and these scotomas are relative, meaning that you can see it if the light's bright enough. But we're looking for these little scotomas because that means very, very early retinopathy. And this lower picture shows where it says OS, that to the right and to the left of that OS, that line disappears. So that's an assumption, but this is more advanced. Color vision we talked about, we'll skip it, but early, what we're looking for is early retinopathy. And these are patients that have normal vision, normal fundus exam, they're reproducible scotomas on the field test, and they have normal vision. But we can pick these tests up early, and that's why we're rarely seeing this. I've seen patients years ago who were on chloroquine, and we didn't have the testing we have now. And it's important to pick it up early because I have some patients who have said, this drug is a wonder drug for me, and I'm not going to go off it. And so we cut the drug in half, and these patients do not progress. So we'll talk about that. This is a normal picture. This is a patient with early retinopathy, but a normal picture, and that's why taking pictures is totally useless. That only picks up changes that are very, very late. And these are patients, late patients. These are patients who say, yes, something's wrong with my vision. I'm losing the cursor on the computer. I'm losing the badminton bird and these other changes. And we want to pick it up early because even if you stop the drug, 2/3 of those patients can get worse. This is an example of a severely affected patient that will show up on the fundus picture, on the retina picture, but it's unnecessary. And these are other tests. So let's talk about screening. There's never been a case in less than 2 or 3 years. So you don't have to be examined right away. You should have a visual examination, and you should be dilated once to look at the macula to see if there's any corresponding retinal disease or macular degeneration, which is much more common in older people. I don't do a Humphrey or a visual field. I think it's unnecessary. We did it for years, and these patients now are having unnecessary tests, and we'll talk about the frequency and how these tests should be done. There's a third technique, an objective technique called autofluorescence, and you can see on the visual field, there's some little scotomas there, and here is where the arrow is a area of hypofluorescence, which is a sign of early retinopathy. This is a patient, however, who has the relative scotomas. You can see on the left the scotomas, but if you look at the lines, I don't have a camera, but at the bottom you see that very fine line that goes across. That's the photoreceptor, and this patient has early retinopathy, very, very, very early, but the OCT is normal. So sometimes the tests are normal. Another normal test. This is a patient with scotomas and an autofluorescence test, which is normal. So the tests, we're defining retinopathy now as visual field test and a second test, either an OCT, autofluorescence, or a multifocal. But these are very, very early signs, and that's what we want to find. So who's low risk? If you've been on the drug less than 5 years, and you don't have to be tested except once in 5 years. The rheumatologists want them tested more often because patients get lost to follow-up. They say, yes, I've had a test 4 years ago, but really it was 8. So we'd like to see them every 2 or 3 years. Younger patients are low risk. Patients with other medical diseases such as diabetes, I don't think are at higher risk. And it is said in the literature that if you have kidney disease, the risk is higher, but I have no evidence in all these years of that being the case. So low-risk patients don't need to be seen more than every 5 years initially, and we'll talk about that, because the risk is almost zero. So you don't need tests every year and every 3 months, we've done them for years and they're all normal. So what are the doses that are important? Well, we're going to talk about that because there are 2 weights that we deal with. One is ideal body weight, and we'll talk about that. And one is BMI. BMI is obesity. It has nothing to do with the dose that your rheumatologist is prescribing. The patients who get in trouble are the small patients who are 5'2", 5'3". They're given 2 pills a day, and they're at higher risk because these drugs are not absorbed by fat. And so more of it goes into the eye, and they are at higher risk. And we'll talk about that in a second. So what is ideal body weight? Well, it's obvious when you look at somebody if they're ideal. I'm not. And this is an article I wrote that it's what you weighed when you finished high school and what you weighed when you married the first time. And they actually published that. I put it in as somewhat facetiously. But you can calculate your own ideal body weight. Males are, and this is rough, depending on your muscles and everything else, but you're basically 100 pounds and 5 pounds per inch over 5 feet tall. So if you're 5'5", a woman should weigh roughly 125 pounds. It's very light. And the problem is the Americans have said, well, we don't have to pay any attention. We just give everybody the same dose of 5 milligrams. But we are going to overdose our small patients if we do that. So we're having a fight with them. And when the Americans talked to the rheumatologists last year, there was a huge battle because the rheumatologist said that's nonsense. So obesity is BMI. And the problem is that half of us are either overweight or obese. And here's an example of a 5'3" woman who's 190 pounds. If you go by the ideal body weight, she's underdosed. But by ideal body weight, she is actually overdosed. and this was really the take-home message, that if you are less than 5'7", you're not overdosed at 400 milligrams, but you're at the top of your dose and you should be checked every 6 months. Patients who are underdosed, one pill a day, I don't think I've ever seen ever a patient being affected. But as I've said, we have 122 patients now that I've seen the last few months who've been on 20 years. 111 were Plaquenil, 5 were chloroquine, and 5 were chloroquine switched to Plaquenil, and only 1 patient was affected. So I think it is safe. If you do proper monitoring and not over monitoring, right now we're over monitoring. If you pick it up very early, these patients have 20/20 vision and they don't progress. It's important that dose is important, and we are concerned that the small patient who's taking 2 pills a day may be overdosed, and they have to be looked at more carefully, meaning they'll need a visual field and an OCT. They don't need retinal photographs. Retinal photographs are totally useless because it only picks up advanced disease, and we can pick up changes very, very early now. So we're open for questions. It's a very safe drug, and I certainly saw cases when I came back in the 70s where we were using chloroquine, and we saw advanced cases, but we don't see advanced cases anymore. Any cases we see are very, very mild.
Okay, so thank you so much, Dr. Easterbrook. That was excellent. So I'll go through some of these questions that we have. And like I said, if we do have time, we will do some additional questions. So Lisa asks, she wanted to know, what is the frequency of optometry assessment?
Well, as I say, patients need to be assessed in the first year, and then they really don't need to be assessed for 2 or 3 years. Okay. They don't need visual fields and OCTs and all these tests because they're always normal in these early years. Okay.
Her next question was, and I think you went through some of that. So was the tests or procedures, what tests or procedures should optometrists do? So this is not an ophthalmologist like yourself, but an optometrist.
Well, one of the difficulties is the optometrists buy retinal machines and then charge every patient they come in for these tests and to pay off their machine. So the tests that within 5 years, you don't need any tests. After 5 years, you should probably have a OCT and a visual field test. If that is normal, you don't have to be checked for a couple of years in terms of that testing. So and the reason for that is that we over-tested for years, and it is costing the healthcare system an enormous amount of money to do unnecessary tests.
Okay. And last question for Lisa was, should additional consideration be given for someone with MS who has an optic neuritis before and so has some changes on exam that could be from that or from glaucoma?
Well, we can readily distinguish macular degeneration, optic neuritis, and glaucoma on the basis of visual fields and other tests. So I don't think there's any evidence to suggest that a multiple sclerosis patient is at higher risk.
Okay, excellent. So the next one is from Marlene, and she wanted to know, I've been on Plaquenil for 2 years, and my ophthalmologist does imaging on an annual basis. My results were fine. Are there more subtle changes in vision that could affect my balance?
There aren't any changes from Plaquenil that it can affect your balance from my point of view, from an ocular point of view. The patient doesn't need to have testing done. You know, if she's only been on the drug for 2 years, she doesn't really need to be tested for 5 years. She can be seen every year and a year and a half, but it's unnecessary to do these tests for 5 years.
Okay. I have Kristen. She's actually currently, this is a, so I guess you'll let me know and I could forward that information to her. She's looking for an ophthalmologist. She moved from Toronto to Guelph, and so she's in need of a new ophthalmologist to take over her follow-up eye care as it relates to retinal health. She's a longtime user of Plaquenil, and she wanted to know if you can recommend someone, an ophthalmologist in the area of Guelph, Hamilton, or Kitchener-Waterloo that are well established in their field.
I would call McMaster, the Department of Ophthalmology, and ask for one of the retina surgeons that's interested in Plaquenil.
Okay, so I'll probably get that from you and then I'll forward it to her.
Good.
Okay, then Ajit had a few different questions. Her first one was, what exactly is the impact of taking Plaquenil on the eyesight and what areas of the eye are affected?
Well, the central part of your vision is called the macula, and that is the macular vision at 10 degrees in all directions that we do when we do visual field tests. And those are the changes that we can pick up with the Humphrey visual field test that patients who are affected have no symptoms. They see perfectly well. And unless these are advanced changes that show up either by all the other tests, we can pick these up very, very simply with the Humphrey field, and it is very reproducible, and it affects the central part of the vision.
Okay, excellent. Now, I know you spoke about dosage earlier, but this is one of the questions, so you might have answered it in your presentation, but I'll just present it to you again. How much of an impact does the level of dose of Plaquenil have?
Well, the toxicity, when we used to see more toxicity, was related to duration, how many years, and the dose. And if you're 5'2" or 5'3" and you're taking 14 pills a week, you're at the upper end, certainly at the maximum dose, and you have to be checked more frequently. If you're only taking 1 pill a day every couple of years is enough. So the dose is the most important. But as I showed you in the slide, of patients that I just saw in a few months, every patient that came in who'd been on 20 years, I recorded, and only one of the 122 patients developed retinopathy. So the risk is very, very, very small.
Okay. Next question is, what tests enable you to determine the impact the medication is having, and how do you differentiate from the loss of vision due to age and general health?
I've only had one patient in all these years that we couldn't separate Plaquenil toxicity from age-related toxicity. And that's only one patient. So we're very clear about different tests that we can use to distinguish different eye conditions that do affect the eye.
Okay. And the last question, if the medication is impacting vision, what are the alternatives?
Well, it depends how badly it is. For instance, if you have early retinopathy, in other words, you have some visual field changes, you're asymptomatic, your vision is normal, the multifocal is normal, but the other tests, the more advanced tests, the OCT and autofluorescence are normal, then your risk is 0 of this getting worse. And that's why we want to pick it up early. And the risk is and I've had, as I said, some patients who we've cut the dose in half and their minor changes have not progressed. And they're normal, they have normal vision.
Okay, perfect. Okay, and Paulette would like to know, okay, this is a little, so I'm gonna go slowly. Do the Optimap retinal exams more helpful than using dilation in regards to identifying the risk with HCL? I'm a lupus patient. Sorry. Okay, so I'm a lupus patient that has partial exams with my optometrist every quarter, plus the annual exam with the Optimap and other tests.
Well, the Optimap will only pick up changes with advanced disease, and they should not be done. You don't need to have retinal pictures done. You don't need to see anybody every quarter. A patient should be seen if they're at the high dose. If they're taking 2 pills a day and they're less than 5/7, they should be seen every 6 months with a visual field. But as I've tried to say, the pictures of the back of the eye by any photographic technique only picks up advanced disease. So it is a useless test. And also these patients are being charged for it. It's unnecessary.
Okay, so thank you very much. Those were all the questions that came in advance. Joy Phillips, who is also part of the Support and Education Committee, is been monitoring the chat. So at this time, if there's any question, if you want to put your name in, actually, which is good, you could put your name in or you could put the question. And I'm going to turn it over to Joy at this time for the questions that are in the chat. But before we begin, someone wanted to know if this webinar will be posted on the Lupus Ontario website, and yes, it will be. Dr. Easterbrook has given us the authorization. So once he's completed it, he'll forward it to us and we'll be able to post it on the website. So Joy, would you take over from here, please, with the questions in the chat now? Thank you.
Sure, Sandra. Thank you, Dr. Easterbrook. So we have a few more questions. Paulette has said that she would like to ask another question. Paulette, would you like to unmute your microphone and ask Dr. Easterbrook your question?
Yes, hi, Dr. Easterbrook. Can you hear me okay?
I can.
Good, good. I was the one that asked the question about the Optimap. Thank you for answering that. Just to let you know, I am under 5'3", and I have been on hydroxychloroquine for quite some time now, like a couple of decades. Would it be warranted for me to sort of discuss this with my rheumatologist and ask them if we should look at reducing the dose? Because I am on 400 milligrams per day, 6 days a week.
Well, we certainly, when we see patients under 5'6", and they're taking 2 pills a day, as you know, if you've been on 20 years, then you know the risk is small. But more and more, the rheumatologists are reducing the dose because there's no question that the total dose is important. The daily dose is the most important thing. Duration is next, and I think that would be reasonable to ask the rheumatologist if. Now, but you should have, if you've been on 20 years, at least every 2 years, not every year, you should have a multifocal, a visual field, and an OCT. And that's all you need to do. You don't have to have pictures done.
So a multifocal.
Now,
and
the multifocal is done in Toronto and in London.
Oh, right.
And I believe in Ottawa. And it's the most sensitive test, so it's not as important as the OCT and the visual field.
Okay.
Those are the important tests. And it's reasonable in your case to do that every 1 to 2 years without pictures.
Okay. Yes, thank you.
Thank you.
Great. Okay, so we have another question. It's from Kristen. So she says, thank you for reading my question, Dr. Easterbrook. You mentioned McMaster, calling McMaster to ask about a surgeon who's interested in retinal health and Plaquenil.
Mm-hmm.
I guess Kirsten, my apologies, has tried this, and unfortunately the receptionist does not return calls. So can you recommend a colleague?
I can't, because those of us in Toronto have been doing most of the writing about this disease. So I don't know anybody specifically, but what I would do in that situation is find out from the website who the professor of ophthalmology, this is COVID, we're not getting back to patients because of this, it's such a horrible mess. Mm-hmm. Find out who the professor of ophthalmology at McMaster is and send him a note. It's saying, I'd like to see someone who's interested in Plaquenil because I've been on the drug a while.
Great, thank you.
If you send a letter, they have to respond.
Dr. Easterbrook, can I ask you a quick question? I'm not meaning to put you on the spot because you just mentioned COVID. And, you know, of course, the contact with patients, especially reference, is extremely difficult at this time with not just ophthalmologists, but with doctors in general. Are you in Toronto? Are looking forward, do you take on any new patients at this time? Or is that something that's basically on hold for the time being?
No, patients who are referred by their optometrist or physician, of course, we will see them.
Okay,
And that's not
perfect.
an issue.
Okay, sorry, Joy, you can continue. I think there was a couple other questions. Go ahead.
Okay, no problem. Let's see. Oh, okay. So this is from A U Hing Wan. I apologize if I'm mispronouncing. So the question is the prognosis of drusen on the macula? Question mark.
Related to Plaquenil or not related to Plaquenil?
Let's see.
Like,
So A U Hing Wan.
Yes, related to Plaquenil.
Oh, go ahead.
so,
Yes. Hi, Dr. Easterbrook. It's Andrea.
Hi, how are you? We have no evidence. There's two kinds of very tiny drusen that older patients get do not progress to macular degeneration, but the larger ones can. But there's no evidence that patients with drusen are more susceptible to Plaquenil. And we can distinguish the field defects, and there's a variety of ways to distinguish macular degeneration. And as I say, there's only one patient in all these years that we weren't sure which was which, because it's very clear they're different.
Okay. Well, I'm being shipped off to Sunnybrook to check in tomorrow at the eye clinic there. So I'm sure you'll be contacted because
I was on staff at all the hospitals in Toronto, so please say hello to everybody for me.
I will. Well, I hope they can figure out why I feel like I have a film on my eyes after a big boost of prednisone. Oh, goody.
That's not unusual. People who go on high doses of prednisone have some visual disturbance for a while, and we don't know what it is, but it gets better.
I hope so.
Good.
Because being in a flare, it's not getting better.
Yeah, well, my experience has been that when patients are in a flare and they get a big boost, their vision goes wacky for a little while, but it always gets better.
Okay.
Now, patients who are on long-term prednisone more than 10 milligrams a day can get cataracts, as you know, but that's a persistent change. That's not a sudden change in vision.
Yeah. Well, I know where your office is if it doesn't get better.
Okay, call me anytime.
Thank you for that.
Pleasure.
Great. So Sandra, it looks like those are all the questions.
I think I see one here. It's from Jacqueline. It says here, if street lights looks like Christmas tree, does that, that came to me privately, so you wouldn't have seen that, Joy. So it says if street lights look like Christmas trees, does that indicate hydroxychloroquine problem?
No, never. Patients who have more advanced disease, in other words, the scotomas are more, they will complain of missing the cursor or the badminton bird, because there's little areas they don't see. But that problem with the lighting problem is either related to astigmatism, glasses change, or little cataracts from prednisone.
Okay. And Sarah wanted to know, how often again should you get a visual? She just wanted
You're frozen.
to reconfirm how often should you get a visual field test?
Well, it depends on your dose. For instance, if you're 1 pill a day, you probably never. If you're less than 5, 6 and you're on 2 pills a week, you probably should be doing a visual field and OCT every 6 months to a year. But if your tests are normal, you don't have to have those tests repeated for 2 years. You don't have to do them manually.
Sarah says 1 pill a day.
One pill
She's
for
on.
for how long? How long she been on 1 pill a day?
Let's see.
Sarah, can you answer
Oh,
that?
10 years.
10
1
years?
pill a day for 10 years.
Only 1 pill a day. Well, I've never seen a patient, and I've seen lots of patients over the last many years, never seen a patient on 1 pill a day develop retinopathy.
Great, thank you for answering that.
You're welcome.
So Kathy actually has a question. Kathy.
I'm no longer on Plaquenil. I was on 50 to 80 milligrams of prednisone for over 20 years. So I have the cataract thing making the film, but they say they're not ripe enough to operate on. Is there any solution a person has until they are ripe enough?
Well, that's an old term. When patients come in with cataracts, you ask them one thing: can you do everything you want to do, i.e. driving and reading with a good light?
No.
Then the cataracts are significant, and the risk of cataract operations are very small. You hear about the good results and the very rare bad ones. But the issue is, like, I had an engineer come in the other day. He couldn't see the big E, but he can read. He doesn't drive a car, so he was happy. So you don't touch him. But if you're not able to do what you want to do, either because of the cataracts you get from prednisone cause a lot of difficulty reading and a lot of trouble with glare.
Yeah.
And if those are big symptoms, then you tell your ophthalmologist you want the cataracts out because you're unhappy. And once your cataracts done, you will be happy.
So the way to get to an ophthalmologist would be get my optometrist, who's 4 hours away, to refer.
Yep.
Okay.
No problem.
Thank you.
Welcome.
Right, so it looks like those are all of the questions from the chat.
It's been fun. If you have any other questions, michael.easterbrook@simpatico.ca. Send them to me. Be happy to reply.
Okay, I'm
Appreciate
gonna
your
tag
time
that.
today.
I'll tag that Dr. Easterbrook. Sorry. Okay, so Michael.Easterbrook.
@simpatico.ca.
Okay. Oh, I think, let me try. Joy, can you try that for me? Oh gosh. Sorry, I just realized I had my system off. Okay.
Just wanted to say
Any
thanks for
last
your
minute
time today.
questions before we go?
I just wanted to say thanks.
Thank you. It's been fun.
Yes, thank you very much. That was very helpful.
Thank you, Dr. Easterbrook. I really appreciate your help.
You're very welcome. Anytime. That's what we're here for. I've had the opportunity of meeting hundreds of wonderful people, and many of them had lupus. Thank you.
Okay, so if we don't have any other questions, this will be posted on our website at lupusontario.org. And for those on the call, I know a number of you might have been waiting from the presentation that was done in October. We did get confirmation from Natalie from Toronto Western, and those are now posted online also at lupusontario.org. If you do think of any questions after this presentation, again, you can reach out to Dr. Easterbrook again, or you could forward any questions to support@lupusontario.org. I would also like to, sorry, I think I wrote a note here. I just wanted to take a personal thank you to Dr. Easterbrook, who's also my doctor, and he's been my doctor for over 30 years, I guess.
No.
So I do appreciate you. I reached out to you and you graciously agreed to do this. And again, like you see, we had a lot of interest. So thank you for joining us today, for informing us about, Plaquenil on the eyes.
Thank you for the opportunity.
Okay.